take your seats. It's a pleasure to introduce Dr. Farkas. She's our new chief of colorectal surgery, and here about a little over 2 years. Having come from Duke most recently, really to consolidate our program in the management of patients with diverse diseases and involving the colon and rectum, and really kind of taking the helm in consolidating and developing our rectal center of excellence. And she's going to present on our recent trends at UC Davis. Dr. Farkas.
Thank you. So if you notice up here, there's a site that you can go to. So if you can go on your smartphones or on your computer, so everybody can bring out their devices. And this is kind of like a survey. It's not a CME question, so it's not like there's an answer in my talk that you can wait so you get the answer right. But we will go over what is the correct answer by the end of the talk. So for colorectal surgeons, we kind of divide our life up into 3 worlds. And we look at those patients who have the benign rectal disease, the benign abdominal disease, and then our cancer patients, which we limit ourselves distal to the ligament of Treitz. We do not do Whipple's, we do not do duodenal carcinomas, even if they are found in our FAP patients. But we're going to concentrate just on rectal cancer. And rectal cancer, for us as colorectal surgeons, I was always taught, you are the captain of the ship when it comes to rectal cancer. Because as a surgeon, we have to really coordinate what is going on with the chemotherapy and the radiation and the timing of the surgery. But while I was always taught to be the captain of this ship, I think what we like to think of ourselves is more as the being part of the symphony and maybe helping to conduct it. But everybody really knows what their jobs are, and we're just trying to be somewhat in synchrony and playing beautiful music, trying to get our rectal cancer patients through the process. And we've come a long way. All right, so here's a couple pictures of Cook County Hospital, and as you can see, in the 1890s, no masks, no gloves, just operating away. And this is the Hectone Theater. This was our place of education. And when John Murphy was there, resident would present a case, patient would come in, hop up on the table, and they would perform surgery with everybody watching. And then later, it became the center of where, the autopsies were done as part of the educational process. When I was there, this is where we stood to do our M&M. The slab table was still there. So we didn't have all this nice, beautiful electronic. We stood in front of the morgue table, and that's where we presented our M&M. So this is just a little introduction, so hopefully you guys are all filling out the survey. So for colorectal surgery, from the 60s to the 80s, we really concentrated on how we can get our patients screened. How can we do better and prevent colorectal cancer? And then through the 1990s, we really concentrated on different ways of technique, especially minimally invasively, and can we do better for our patients? Through the American College of Surgeons, who has always been working on quality for our patients, just recently in 2017, we have now started a national accreditation program for rectal cancer. And so it has joined with all the NISPWIPs and the CSWIPs and the bariatric programs and the pediatric programs, that this has been found to be an area of much concern that we have to build up our quality. So just a quick survey in regards to colostomy rates in the United States for all rectal cancers. Everybody raise your hand if you think our colostomy rate is 10%. 20%. Of all the patients with rectal cancer, how many get an APR? So we'll start again. 10%, 20%, 30%, 40%, 50%, 60%. Do I hear 70%? All right. So we look at a lot of things to look at what our quality is, and colostomy rates is one of them. All right, in America, colostomy rate. Looking at the nationwide inpatient sample, 25% stratified patients, 41,000 patients. Our rate is 60%. Even if you look at it over time, we pretty much plateaued in the 1990s, and that's at 51%. That is our national rate. I was always appalled when I was an assistant professor at University of Pittsburgh, and the patient's like, I'm going to get colostomy, am I? I'm like, no, you're not. Well, now I know why, right? These are why patients were scared. Same group of people looked at it a little differently, looking at 21 states where they had county data. And you can see that there's a great variation. And they showed a 50% APR rate. And only 20% of the counties had a rate less than 40%. So Olympics were just here, right? So do we win the gold throughout the world for our colostomy rate? I mean, it's bad, but maybe we're still the best, right? Well, if you look at a lot of the national trials that have been done through Norway and Sweden, the German trial, the Australian trials, and these were trials where they were comparing on their rectal cancer patients timing and different type of chemotherapies. So we have the data to know what their colostomy rate is. There we go. So we're not the hockey team of women, we are the hockey team of men who lost to Slovenia. So they're all in the 30% range. So we're not doing that well. How did everybody else do so much better than America? Well, the Norwegians pretty much showed us how they did it. They started back in 1993 with Dr. Held, who kind of championed the total mesorectal excision, and he did workshops and taught surgeons how to do a TME. When they started, they had a 15 to 20% local recurrence rate. They did this trial from 1994 to 1997, and basically you can see they increased their TME rate from a baseline when they began at 78% and improved it up to 92%. This in turn increased their 4-year survival, and they decreased their local recurrence rate by half. And you have to remember that in Norway, basically, they don't believe in radiation either. So they got a 6% local recurrence rate without even using radiation on their patients. So Sweden next door, not to be held up differently than their neighbors, they also, during a time, had a consolidation of 4 centers into a center of excellence and taught their surgeons how to do a TME. And again, they also were able to increase their survival and also decrease their local recurrence rate in half. And this has been reproduced by many other nations. Spain was able to reproduce and decrease their local recurrence from double digits down to single digits. And also Ireland was able to decrease their circumferential positive margin. So when we look at rectal cancer, we want to know how low can we go to get a negative margin. Our proximal margin is pretty good to get negative. But there's that circumferential margin around, which is also a quality indicator. And also they were able to decrease their leak rate. So it was time to get our head out of the sand. And quite apropos, ostrich was born, optimizing surgical treatment for rectal cancer. And basically, this was headed up by Dietz, who was at Cleveland Clinic with Feza, once now at Case, one's in New York, Wexner, who's still in Cleveland Clinic, Florida, and Monson, who really helped champion it because he was in England during all this time of consolidation. And he was able to bring to America what they did wrong in Europe and what we can do better in America. And we partnered with the American College of Surgeons in regards to this endeavor. So I was very fortunate to be able to be part of the manual where we started to set up what was going to be the standards, and also will now be a review of other sites, because sites will be reviewed as they decide to become what we're not going to call a center of excellence, but just an accredited site. So I'm going to run through kind of what it is going to be required to be accredited. So on baseline, we're talking about rectal adenocarcinoma. There are some adenosquamous patients and should be included along with metastatic patients, because we're not going to say metastatic patients don't matter. Their local recurrence matters, and we still can get cures with our metastatic patients. And so we started in April 2014, so about 3 months after I got here, doing deliberate practice as a team, because the manual wasn't quite published yet, but yet I did kind of have an idea what was going to be in it. So we practiced. And some things we were able to do very well, some things we were not. So to be accredited, we have to be part of the Commission on Cancer Center, and UC Davis has been one since 1973. So we get our little green star of good. So we started out, though, initially in 2016, there was still kind of a divergent amount of surgeons that were doing rectal cancer. Only 66% of our cases was done by someone who was a member of the multidisciplinary team. So in 2016, we would not have met accreditation, but in 2017, that was able to be me. To be accredited, you have to have a representative of each one of these type of specialties. And at least everybody has to be there at a meeting. And so if radiation oncology doesn't show up, that meeting doesn't count. And each member has to show up at least 50% of the time with their alternate. However, very special is the director and the coordinator and us as the surgeons. We don't have alternates. We have to show up at least 50% of the time. And so this is our team. As you know, this is our surgical team for colorectal surgery. And for medical oncology, we have 4 medical oncologists who participate. So what's for them, you know, Dr. Tam, and between Dr. Tam and Dr. Cho, they need to show up 50% of the time. And the same thing in regards to radiation oncology, though we're working on an alternate for Dr. Manjazab, and also for pathology, and also for our MRI radiologists who help do the reads. So in addition to the whole team, I'm very thankful for some of the little cameo appearances we have with our hepatobiliary surgeons and our thoracic surgeons who come to help out intermittently when we give them enough head notice so we can discuss some of our metastatic patients also. So it sounds real simple to get everybody involved, but it's not. And so, you know, if you look at each of these, so each row is a division, okay? And within a division, you can see different colors, and that represents a different position. And a black one means that that division did not have a representative that day. So right away, you can see there's a bunch of meetings in 2016 that would not count. And of course, we didn't know at that time, but you know, we had to have truly a visual webinar for someone to be able to be counted within their division. And then you can only have one alternate. So like Dr. Tam can only have Dr. Cho as her alternate. She can't also have Dr. Tanaka be her alternate. So, you know, we tried, right? And only 6 of our meetings would have counted that year, looking back retrospectively. 2017, we started getting a little better because people start showing up, and but we're still at 10. So this is going to be something we really do have to work at. The director and the coordinator has to be at least 50% of the meetings. We will have to be doing quarterly presentations and also a yearly presentation to our home COC site. So these are somewhat new that I just found out within the past 3 weeks. Eventually, each of these specialties, surgery, pathology, radiology, endorsed by their basic society, that we're going to have to take either a test or some type of an educational module, again proving that we know what is the standards for surgery, or pathology know what is the standards for the assessment, and same with radiology and how to read a good MRI. We're doing very well in noting that patients have to have a confirmed biopsy before we start treatment. But newly started is that these slides have to be reviewed by someone on the radiology team. So it could have been read by someone else, but we did make sure everything was read during our MDT. But now we know that does have to be actually reported out by someone on the MDT team. And it's the same thing in regards to the MRI. Has to be read out by someone on the MDT team. So these are little changes that we have to make over time. Also, initially in 2016, we probably didn't really have the MRI program ramped up, and so we did not meet the percentage of cases that should have had been done by an MRI prior to surgery, but now we're meeting those parameters. It's amazing just to having a CEA before treatment. I mean, we blow that out of the ballpark. We have 98%. But when we surveyed other centers who were thinking about being accredited, they listed this almost as their number one impediment that they thought was going to prevent them from becoming a site. But we did that quite well. And then there's a lot of coordination, and that's why we have a nurse coordinator. And, this is going to be part of the parameters that while we have to discuss everything before we start treatment, we actually have to generate a summary. And that summary needs to be sent back to either the primary care doctor or the referring doctor. And it's very specific what needs to be placed on that summary. But it's things that should be on there. What is the stage of the patient? What were the studies? Is the sphincter threatened? Are the margins threatened? And are we recommending neoadjuvant therapy? And if so, what type and how many cycles? And was their patient eligible for a clinical study? 80% of the patients have to start their treatment or have their surgery if we decide not on neoadjuvant therapy within 60 days. And we have been meeting that criteria very well. And depending on when the clock starts ticking, depends on if the biopsy is done in-house or if they're referred into the program. We eventually will also have synoptic reports for surgeons. And so we are a beta site working with Stanford in regards to practicing what the synoptic report is going to be. Pathology also has to read out their reports within 2 weeks. Our pathologists have been doing a great job in regards to doing that. But again, we have to now centralize who is even reading those path reports. There's a lot of GI pathologists, but if they're not a member of the multidisciplinary team, if they're not on that team showing up 50% of the time, they no longer can be reviewing our rectal resections. And we have to photograph. So now we have to photograph all our rectal specimens in 4 views. So again, we've been practicing, right? So initially, we were kind of taking our own photographs. And sometimes we would say, take out my phone and, circulating nurse, can you take the picture? Or medical student, can you take the picture? And sometimes we get this. So luckily now pathology has purchased, and they have a great electronic photograph system. They're going to take pictures for us, and we're working on getting a shared database so we can upload the pictures. Because after we operate, within 4 weeks, we have to go through the pictures, we have to go through the path, we have to decide what treatment further is the patient going to have, and again, we have to generate a treatment summary. And this is going to be a lot of good help from our coordinator. I tried to do this the past couple years. I may have slightly approached 50%, but in regards to what has to be on it, we have to actually incorporate the pictures of the rectal specimens. Much to my dismay, 3 weeks ago, I found that out. And so this is why we really have to coordinate on a shared drive with our pathologists. We do very well at our patients getting into starting their adjuvant treatment if we decide that they need to have adjuvant treatment. So overall, it looked a little bleak in 2016 and in 2017 because we really didn't know what the parameters were. I think right now, moving forward in 2018, I'm just a little worried about the attendance, and we're still working on the photographs, being able to capture them. But I think we're going to be able to persevere and work through this. So now I'm going to go through some of the UC Davis numbers, but you have to remember the journey of the rectal cancer patient. So once they're diagnosed, by the time they have surgery, they get their ileostomy, they get their adjuvant therapy, and they're reversed, it's a year. So it's a little different when you look at date of diagnosis versus date of patients having surgery. And even with our new study that we're participating on nationally, while they get all their adjuvant treatment up front, then they get their radiation and then their surgery. It's 9 months from diagnosis to the time of their surgery. I can barely even recognize these patients when they come back, right? Because it's almost been a year since I last saw them. But I can say what's going to be exciting, that I hope that this works out for the patient, is that now they're going to live with their ileostomies, maybe just for 2 months instead of 6 months. But still, it's a year in the process of the patient. So these are our numbers from the cancer registry, and they go by from date of diagnosis. So if you look at all colorectal patients, 2015, 2016, 154, 130 some patients. In blue is how many rectal cancer patients came through the registry. And you can see we're hitting at about 30 to 40% of the patients are rectal cancer. Because nationally, it is about 30% of colorectal cancers are rectal cancers. For me, this is going to be a number that I would like to see higher as we become more of an accreditation, a referral center in our region. So this is what we've been doing for the past 2 years. So in 2016 to 2017, first we started off with 81 presentations during the year of 2016, which is actually 8 months. But by 2017, we did 175 presentations. And with that, what that it actually is 43 to 71 patients. Because on the average, patients are being presented about 2.5 times, right? They're being presented when we first diagnose them, when they come back after their neoadjuvant therapy. Frequently we're repeating their MRI, so we have to review that as a team, and then after surgery. So on the average, these patients are being presented 2.5 times, and this is why we kind of had to pull away and do our own tumor board, because the volume is just amazing. And we do talk about some of the non-rectal adenocarcinomas intermittently because we're all together. So this was just, I'll blow through this kind of quickly, but this was just me kind of looking at where the patients came from, The circle is a 50-mile radius. Not much difference between 2016 and 17. This is a 100-mile radius. And then we're even capturing some patients way up by the Oregon border also. But I think what is interesting when you look at how many patients are unique to UC Davis, never been here. The only reason they came here for their very first time is because of their rectal cancer. It's about a half of the patients. So to me, I feel like we're kind of like the stewards of UC Davis. We want those patients to have a good experience because if they do get their liver met, they do get their lung met, we want them to have a good experience with their rectal cancer. We want them to continue their care here. And, you know, we never get hernias from colorectal surgery, but if they do get a hernia, we want them to come back and have their surgery done here by our general surgeons also. So who are these patients? And a lot of the residents have been kind of shocked and appalled by the amount of young patients that we have been seeing. Well, it actually is national. So this was an epidemiology study done through UCLA where they look over time, looking at who is getting rectal cancer. So we're going to concentrate on the top two, and you can see over the years, a number of patients per 100,000 in their 20s and 30s, there definitely is an uptick. Okay? So the disease of the old is not occurring anymore. Because of our good screening, see, it's going down actually in the amount per 100,000 in the elderly, but we're definitely seeing a rise. And there's a lot of people that are trying to change what screening should be because of this uptake. But right now, the screening modalities have not changed. So I decided to take the SEER data on what is the distribution of rectal cancer and look to see how we fit in at UC Davis. And you can see between 2016 and 2017, we are seeing even a little bit more disproportionate amount of young patients. It may be because the young are willing to travel. It could be that, you know, our median age in Sacramento is a little bit lower than California nationally, but we're definitely seeing a big group of young patients. So this is not something that, you know, the residents are just happening to be noting. It's true that we are seeing a difference. So again, looking at our numbers from our cancer center and concentrating just on rectal cancer, when we look at how many surgeries are done, and again, these were by the year of diagnosis, we can see the amount of cases historically were about 8 to 13. And before Benson left as our CAO, I got our 2015 numbers, and they were about 15 cases a year. We're going to come back to that later. So quality data. You know, what is deemed quality data for rectal cancer, a lot of us disagree, and they probably will change. So this is considered quality data for rectal cancer. And we sit way over here to the right, which is good. Over here to the left is bad. And this is looking at the patients who do get chemoradiation before surgery. Well, the thing is, times are changing. We're not going to do chemoradiation very much anymore for the stage 2 upper rectal cancers. So while this is a data of quality, it probably will no longer be collected anymore because some of the centers who are following here are probably just being more progressive. So we talked about that on our last conference call. Amount of lymph nodes harvested is 12. Now that's more for colon cancer because if you only take 8 lymph nodes, so that makes a patient maybe a stage 2. How do you know if you didn't get 15 lymph nodes that now you don't get a positive lymph node in your stage 3? So there's very good research saying 12 is the number, and that has somewhat been ruled over into rectal cancer. Quite honestly, for the NAPRC, we're not going to use that as a number, as a quality indicator if someone has had radiation. Because as you can see with the NCDB database, the amount of lymph nodes greater than 12 in their database was captured was only 65% of all surgeons. Certainly, if they didn't have radiation, much better chance of collecting lymph nodes. SEER is also kind of in that area of about 67%, but that is used as a national quality. So for UC Davis over the past 2 years, and remember this is a quality indicator that's a team sport. It's the surgeon taking out the lymph nodes and also the pathologist digging through the specimen and finding these lymph nodes. And we are hitting it out of the ballpark. We're doing great. Only one patient, we had less than 12 nodes, and it was someone who did receive radiation. So looking at colostomy rates, is this a quality indicator? A lot of people want to use it as such. I guess globally you can use it as an indicator. We always talk as colorectal surgeons. We don't want to have it used as an indicator to compare one surgeon to another, because what do you do with patients like this? You know, a patient who has cancer perforated into their sphincter, eroding into their sphincter, and going into the sacrum. I mean, it's a good operation to give these patients APRs. But I guess what the spirit of this being a quality indicator is that the patient who has a big bulky cancer, right, or the patient who has a huge big bulky mesorectum, that just because of this, that they don't get an APR. I mean, a lot of us, probably older surgeons in the room, can remember our general surgery textbook that used to say, if you can feel the cancer with your finger, that's an APR. But no longer is that. So I guess that's the spirit of everything. So is all this really worth it? Certainly the Europeans have shown that doing all this effort, they have increased their quality. In fact, in parts of Europe, their survival for rectal cancer is now better than survival for colon cancer because of all this. And certainly in America, we desire quality for our patients. But let's face it, hospitals we're corporate America, right? So is this really worth it? So I did this little exercise with the help of the CAO from Radiation Oncology, Jennifer Kellogg. And actually, we looked at how many more surgeries were done from 2017 from historical, such as 2016. And we know that the hospital from Medicare gets anywhere from $40,000 to $60,000. So let's say $50,000. Bonus, $700,000 over 2017, just from surgery. She was able to share with me how many more additional patients in 2017 got radiation traditionally over 2016 and 2015. And those were 26 patients. The medical allowable net payment for technical fees or for facility fees, and we know how many patients get 2 different types of modalities of radiation. Plug in these numbers. I want a bottle of wine from the radiation department. So they got an additional of 2.5 million. So we're adding a lot to what can help within the hospital numbers. So 2018, we have already done 12 rectal cancers. Now, we know that those numbers won't continue on. It's like rain last year in Sacramento, right? We got lots of rain. It's not going to continue to rain that much. But if it did rain that much, we would be doing 72 resections this year for rectal cancer. But even if we just give the numbers of 48 and go through the same numbers in regards to how much money we will have collections for the hospital for surgery and radiation, and we're not even including the chemotherapy numbers. So this is a great program for the hospital, in addition to the quality we want to give to the patients. So let's see how many of you guys did this survey, but you can see what the answer is for the first question. So the first question was, what is the lowest number of cases does one individual colorectal surgeon have to do to be in the top 1.3% of the surgeons in the United States? So let's see how many of you guys filled out the survey. So most of you thought probably an individual surgeon had to do about 30 cases, right? It's only 16. And then the second question, looking at hospital-wise, how many rectal cancer surgeries per year is done at any given hospital to be in the top 1%? And so, again, most people are thinking about 50. So the numbers that I'm going to share are from the Nationwide Inpatient Survey, and these are given to me, very much thank you, Dr. Hallaby, and I'm not going to steal his thunder for what is really what this part, where this data came from his study, but this is just to give you an idea of if you look at surgeons who do at least 16 rectal resections a year, that's the top 1.3% in the country, okay? So you can see 90% of the rectal resections done in the Nationwide Inpatient Survey are done by surgeons who are doing 1 to 5 patients a year. And that is 61% of the patients in the survey. Again, looking at the top, only 2.4% of surgeons are doing at least 11 a year, and that's about 20% of the patients. So in 2016, I started in January. I didn't even touch a rectal cancer patient until June or July. So these would be my numbers in 2016. And in 2017, I've done at least 16 patients. Now, if we look at volume for a hospital, okay, 97% of the hospitals are doing 20 or less operations within their institution, and that's 63% of the patients. Again, only 0.9% of the hospitals are doing at least 40 cases a year, and that's about, 13 and some percent of the patients. So this is where we were somewhat historically at UC Davis. And down here, last year, we reached up into where we are in the top. We're up in the 3% of the hospitals, but I'm competitive in nature, and so this is where I would like for us to be by 2018 and by 2019, and I think we can get there. It hasn't been easy, right? But that's what life is all about, and we pretty much have done this from scratch on a shoestring with a skeleton crew, but we're growing and we're getting there. But that's okay, right? Because I've been here for 2 years. Probably not too many people know a lot about me, but this is where I grew up, Curtisville, Pennsylvania, whopping population of 1,000. But my whole school district was that, whopping population of 15,000. And so it sits in Allegheny County, which is down here, and this is Pittsburgh, right in the middle. You can still get a really good house in Curtisville. So everybody who's just, can't afford a house in Sacramento, you can get a great deal in Curtisville. And, so median house price, $80,000. But this is my neighborhood, right? You get it done. You get it done. When these are your uncles, these are your grandfathers, these are your neighbors, they say something, you get it done. And, the spirit is still very tenacious there. We have all volunteer firemen, volunteer EMTs. So I can tell you, in putting this program together, we had lots of great candidates to hire for colorectal surgery. But all right? This is who we have, because he has the same grit, and someday he may share his story, but he has that same grit that it's going to require for us as a team to get this program going. And so it's kind of been like a one-man band. And no, not related to me, but I just had to put it in. And if you ever see the Wyos, they're wonderful. And yeah, I just had to put that in. But this is the team, right? But I just have to kind of show you my the unsung team that has allowed this to happen. And a lot of the residents, if they're standing during our 8-hour operations, we tell our stories. So this is my daughter, who's the free spirit, who psychology degree, but now living up in the Catskills of New York, and makes her own bread and has her own ducks. And yes, this is the guy who I make you listen to his music in the operating room. It's in a band. But if there is a zombie apocalypse, I am going there. Okay. My other daughter, luckily, thank God, got a scholarship at William & Mary, was Division I gymnast. Very proud. She was captain of her team for 2 years. Now her and her boyfriend, of course the gymnast, are rocking it out now on Park Avenue in New York. My third daughter, who we thought was going to be the tennis phenom, because she and her partner won the, came in second in doubles when she was a sophomore. But lo and behold, at 15, she says, "Mommy, I want a suit." "You want a suit for Christmas?" "Yes, I want a suit for Christmas." And I've decided I want to go to school that is close to the Capitol, that has like a high electoral vote. So here we are at UC Davis, and we'll see what becomes of this one. But now you guys all have the face to all the stories. So thank you all for your attention, and I think we have a few minutes. I could take some questions if anybody has any questions.
Dr. Farkas, I'll ask a question. The European experience you cite is pretty dramatic with the standardization of surgery. I mean, obviously, total rectal describes very precise surgery, which those countries were very successful in standardizing across what was a relatively homogeneous population and national health system, so they had some control. And even, the Netherlands sent people out to watch the surgeons to see how they perform the technique. The growth of your program here, even in its relative early stage, is very dramatic. I mean, it offers something quite exciting to, let's say, the population in Northern California. It's very, very tight quality control, the standardization of surgery, et cetera, et cetera. As your collective group, your national group looks ahead, what's the how will this be applied to society? Can we create programs like yours, which instead of increasing volume, specialty centers and so forth, or can that be universalized to standardization of surgeons? Just as you look ahead, there's almost certain success of your program here, but then how is that applied across the society, let's say, the Northwest region, Northern California, Northwest region of the United States?
Yeah, I think our society, the American Society of Colorectal Surgery, we're not trying to mandate that there's government centers, right, like they do in Norway and Sweden. What we're trying to do is to have a standardization such that we all speak the same language, our pathology is all looked at the same way, our surgeons are operating similarly, we're pre-oping our patients the same. So eventually we can have like a national database, kind of like what the other countries do. And to use that database for feedback, so centers can know individually what they need to do to improve, and so we can move forward for national studies. I mean, the NSABP R04 study that wanted to look at pre-op and post-op radiation was a failure in America because nobody would accrue, nobody was speaking the same language. But yet, the Germans, the Swedish, the Norwegians, the British have all been able to accomplish national trials because they're a little bit more homogeneous in their care. And I think we're just trying to get somewhat homogeneous in our care to improve our quality. So, I mean, even James Fleshman, who's a very renowned international colorectal surgeon, he was able to improve the quality at Baylor. I mean, Baylor had lots of colorectal surgeons, but, you know, looking at when he started doing his MDD trial, I mean, even at a great center, they were able to even do more better, right? And that's all that we're trying to do. We're not trying to set up government-approved center sites, because we know there's always going to be, you know, not every patient from Crescent City is going to come down here for their care, and not all the patients are going to come here. But I think we do want to give patients information so they understand that, you know, maybe my facility down the road only does one every 2 years, and maybe this isn't the best place for my surgery. But I think a lot of this is going to be used for us to be able to quickly turn around more national trials.
Dr. Farkas?
Yes.
Is there a hypothesis about why rectal cancer is increasing from that age group, 20s to 30s?
Yeah. There's only theories at this time because the uptake is about the same time as the uptake of obesity. The fact that when you look at something like first-degree Japanese Americans come into America and they have a great increase in rectal cancer from their native country. There's also been, you know, animal models where you kind of feed them the good old West Hemisphere diet, high fat, high processed sugars. There's an increase in inflammatory markers within the colonic tract. So that's somewhat of a theory, but we don't know yet. But it's real. And I'm hoping that at least we would be thinking about doing flexes on patients at a younger age as part of the screening. But this is why, you know, someone bleeds, I don't care, they're getting a scope, right? Because I'm not going to have my name on a chart on a 25-year-old who was just, you know, given iron pills and told it was hemorrhoids and had them banded. Because we see plenty of these young patients, and it's devastating. And they all have that same story.
Thank you so much. On one of your slides, you mentioned quality, and then you mentioned that, you know, hospitals are part of corporate America, and then you talked about the revenue as well. Just could you elaborate on that a little more? Have you found attention in quality and being, having it's corporate in nature? Could you just elaborate on that?
Well, you know, there's always, some people look at quality and money as being opposing, right? Because you want great quality, it costs money to do it. But ultimately, how I look at it is, if you do great quality, if your complication rates go down, right? And if patients are able to go out and have a fruitful life after their treatment of their rectal cancer, society or at a hospital level, the ultimate cost should be lower. So I think they really go hand in hand in regards to cost and quality, which is what value is all about, right? Because you want to be able to have that good outcome potentially at a lower price, and that's value. And that's what we're trying to do, I think, nationally through the societies that are interested in rectal cancer. We're just trying to bring better value into our patients because obviously other countries were able to do it. So we should be able to do it also. Okay, thank you.